First of all, we should we're going to discuss about the neurological soft signs found in schizophrenia. Maybe some historical facts are useful to begin with. A neurological examination is always useful, even for us psychiatrists. Firstly, is to determine if there's a major neurological disorder that we should focus on, and this focuses on our main signs, how they're called, like the Babinski sign, or like the differences in reflexes and maybe some muscle weaknesses, which actually states that there's a major damage in some brain area. The second use of the neurological examination is to investigate the possible overall reduction of the human brain and for our patients. Kraepelin was the first one that found out that there's something wrong, something different with the neurological image, with the neurological findings in people with dementia precox back then, but he thought that there's something with a biological background, something that yet is not determined, that had to be determined at that time. So some diseases, as they were called back then, like insane temperament or hysteria, schizophrenia, after some time, mood disorders and obsessive-compulsive disorder were always described like that they had something different when they were compared to normal people. The first one that used the term neurological soft sign was Bender in 1947. After that time, mainly during the decade of the 60s and the 70s, the research about motor clumsiness, how it was called back then, meaning that there was something different, something clumsy, as they said, that had to be correlated with schizophrenia. The term changed after a while, and they used the term minor neurological dysfunction that was popular back then. And of course, because all these movements, all these disorders was firstly described in children, the first effort was to find it was something in pediatric, and then they did some adolescent research, and the adult studies, adults with schizophrenia followed. All these things were a bit vague back then, meaning that if there was not something really hard, really distinguished, the boundaries were not so clear. So people with being left-handed or maybe some learning disabilities, all these things were considered to be soft in a neurological point of view. And they grouped these things and thought that there was a soft thinking, a soft way of the brain functioning. This, of course, led to some, contradictions, and other researchers thought that this was a soft scientific approach, that it meant that something is going on, but we don't know what's going on, so we shouldn't just say that it's not that important. So the definition. Hard neurological signs allow you to detect the brain area that is damaged. It is something objective. It's regardless the patient's age or nationality or whatever, and there are some typical symptoms or findings that everyone can find, like muscle weakness or problems with cranial nerves and so on. Soft signs are deficits of the central nervous system in general. They do not suggest that there is something in a specific brain location or lateralization. It is, for example, a difficulty in distinguishing the left from right stimuli, maybe a problem in coordination of movements, even in balance and walking disturbances. So this segregation was considered back then to be a bit artificial. And of course it indicated lack of determination of brain functions that undergo the existence of the neurological soft signs. Heinrichs and Buchanan disagreed with the term soft. They thought that this meant it could be heard as something vague, something not true, something that could not be interpreted, maybe something that it's not even there. And they decided that we should use something different, something more specific. Though they stated that the uncertainty of the meaning of all these findings in schizophrenia was due to our lack of knowledge rather than the low clinical value of the science, which means that they believed that there's something going on, but we didn't know exactly what that is. So, according to the possible neuroanatomical location of the soft signs, now are divided in 4 categories. Well, most researchers divided in those categories because there are researchers that they think that this division, this segregation should be more or less something different. Well, it is the sensory integration is one group of findings, the motor coordination, the complex motor axis sequence, and the primitive reflexes. So according to the findings and the group of all these tests, what is now currently what is more in use is this segregation. When we're talking about sensory integration, we believe that something is going on in the parietal lobe, and the problems are bilateral stimulant extinction, the audiovisual integration, the agraphesthesia, and the confusion of the problem in distinguishing left from right. When we're talking about motor coordination, probably the problem is in the frontal lobe and the cerebellum. And what we find is tremors, problems in balance, in walking, jumping, opposing the thumb and the finger, and problems in nose-finger test, the classical neurological test. Complex motor axis sequence means that something going on in the prefrontal lobe, and we use specific tests that has to do mainly with the hands and the specific tasks that we ask the patients to perform. Usually they're not that good in that performance. Of course, there are the primitive reflexes, like all know the sucking reflexes, the palmar, the chin tap sign, and all these classical examination. And the hard signs, as we talked before, are some things that we might find in schizophrenia. And of course, that's it's typical in their location in the brain area. So, many researchers have tried to do something about putting these things in position. They found that in general, up to 65% of the schizophrenics have some of these signs, compared to 5% if we compare them with a normal subject. If there is only one sign present, if we decide that we should check only one sign, the percentage can reach up to 100%. There is a problem, meaning that it depends on the definition of the word neurological dysfunction, and the scale that we use have low sensitivity, low specificity, because some of the scales have only they search only for 4 signs, so some of the signs could be not noticed. And some scales use more than 100 signs, which means even some are maybe overdiagnosed. There's no cutoff score, which is also a problem. Though all these things were tried by Chan to be in a conclusion, and he concluded that after a meta-analysis that 73% of the schizophrenic have soft neurological signs. So are these signs a part of a neurological dysfunction that is there before the psychotic symptoms, and or are the result of a degenerative procedure of the brain after psychosis takes place? And is there a meaning in medication? I mean, someone could say that these problems that we find could be a result of people taking our medicine. So what they did, they examined patients in the first psychotic episode. The prevalence was between 20 and 97%, depending on the scale they used, depending on so different aspects of the tools they used to examine these patients. If we stayed in the neurological evaluation scale, the percentage is 97 and more %, but regarding just one neurological sign. If we find two signs, the percentage is at about 63%. The truth is that all patients in the first psychotic episode, they showed deficits in all subscales of the neurological evaluation scale, in their facial expression, some hypokinesia, the tremor in the upper extremities, and cerebellar signs. They were compared with patients with chronic schizophrenia, with first episode patients, with chronic schizophrenic patients. They were compared with the normal ones, and they found that there was no difference between the two groups of the schizophrenics, but there is a significant difference between the normal and the schizophrenics. Also, another research found out that the people with no symptoms of schizophrenia but with high genetic risk, they had similar rates in the findings of the neurological signs, the soft signs. And what's more, subjects with schizophrenic parents also showed a high prevalence with neurological soft signs, specific in motor coordination and sensory integration. So another question that arises is the presence of neurological soft signs a reliable marker indicating a vulnerability towards the psychotic disorders? And the way to answer this question is what they did. They did some cohort studies, including children that later developed schizophrenia. And they found out that these people, in their childhood, they had some motor development disorders, not specific ones, and especially in fine movement coordination. That may be a suggestion that there is a neurodevelopmental abnormality of this dysfunction and not a neurodegenerative. So, the specificity of these signs. Almost every study that's been made showed that that neurological deficit and soft signs are there. Sensory integration and complex motor act sequence are the two categories that are most found when compared with other psychiatric disorders, other mental disorders. If there's a comparison between alcohol-dependent patients, chronic patients with schizophrenia differed in all subscales, not just those two. And when compared with patients with OCD, schizophrenic patients showed highest prevalence, but this is something that has to be checked again, because there's enough studies showing that there is no difference between the OCD patients and the schizophrenic patients, according to these researchers. No specificity could be determined among schizophrenic, bipolar, or other psychotic disorders. The researchers suggested that the motor integration is preferred. Other researchers suggested that sensory integration is preferred. After all, sensory integration and motor complex act sequence appeared more often than in other psychiatric disorders. Though that some methodological questions still remain because there are some problems according to the tools that they used, the patient that they included, and also so on. The tools usually are these examples of some scales that people use. Currently, the last two, the Cambridge Neurological Inventory and the Neurological Evaluation Scale, seem to be more efficient because they include a part of a psychometric tool, psychometric aspect of the patients, which means that it's more useful for our patients. What's the problems in methodology are usually these, that people, researchers, use classic neurological scales, I mean scales that neurologists use. Some of those things are part of a larger battery of evaluation. Most of those are applied in children and then in adolescents and then in adults, which has some differences. Most of them do not contain any psychometric properties. Some researchers disagree about categorizing all the signs, and examiners' subjectiveness is an issue, which means that maybe some further research or maybe something more specific for these situations should be useful. So this comes to why all these thing is important. I mean, or we could say, what do we know so far? First of all, we know that it is there. It's not something that, it is a part of the disease, not something that we have to search in deep to find. It is actually something that it is there according even the first people that described schizophrenia. So we should search for it, we should document it. Overall research showed that up to 90% of schizophrenics have at least one soft neurological sign. This may indicate that there's a premorbid adjustment of these people and maybe an even poorer outcome. It is related with negative symptoms. The more the negative symptoms, the more the signs that we find, and of course with low GAF score. The properties of these signs are trait-like characteristics. They're stable over time, they're independent of social and demographic factors. The clinical features of this disease and treatment are indifferent, which means that it does not have to do with our medication or whatever we prescribe, we do with this patient. The signs are there no matter what. They could help us in diagnosis and prognosis and maybe in therapeutic planning of these, of our patients. And of course, it is free of charge. I mean, it only takes you up to 30 minutes to perform the examination, and since it's free currently, it is really important. Well, thank you.